in hot topic in is subspecialty of orthopedics under the chairmanship of Professor S.S. Mohanty and Secretary Dr. ASHISH PHADNIS, Dr. SWAPNIL, KENY, and myself, Dr. DEEPAK GAUTAM. Dr. Mohanty is the professor and unit head in the Department of Orthopaedics at SUSHRUT Medical College and KENY Hospital, Mumbai, and honorary consultant to Ashok, Nanavati, and SUSHRUT Hospital. He is the past president of Indian Arthroplasty Association and Bombay Orthopaedic Society. He is the education chair of Indian Society of Hip and Knee Surgeons, reviewer of famous journals BJJ, CICOT, and our own Indian Journal of Orthopedics. Today is the day of controversies in trauma. We have our eminent speaker, Professor Vivek Trikha from AIIMS, New Delhi, along with moderators, Professor SUSHRUT BABHULKAR from Maharashtra and Professor AGGARWAL from Punjab. I would now like to call upon Professor Mohanty to introduce our speaker and the moderators and proceed with this session. Dr. S.S. Mohanty, sir, all to you now.
Thank you, Deepak, for kind introduction. So, friends, greetings from Mumbai and welcome to the 12th episode of Controversies and Consensus in Orthopedics. Unfortunately, we could not hold this during the last Wednesday because of some unavoidable circumstances, but we'll continue to do it, again every twice in a month to continue on different aspects in orthopedics. So we have three eminent, professors from different parts of India today to sweep us through to again another controversial topic about how to fix the fractures at extreme of tibia, that means upper end and lower end of the tibia. Our eminent speaker today is Professor Vivek Trikha, who is a professor at Jayaprakash Narayan Trauma Center at All India Institute of Medical Sciences, New Delhi. He has obtained his medical training as well as he has more than 25 years experience from the AIIMS itself. He's an international and regional faculty for AO, CICOT, APOA courses in orthopedic trauma. He was a former AO research officer of AO Trauma India and more than 750 talks in various conferences courses. Commonly in trauma meetings is a known face. Is a CICOT Education Committee member, academic cell in charge of IOA, AO coach for the faculty. And over 150 PubMed Index publications. He has a patent for pre-hospital immobilization device. His special interests includes pelvic surgery, complex intra-articular fracture, skeletal infection, trauma basics research, and trauma education. Welcome, Professor Vivek Trikha, today to this episode of webinar, and thank you for joining today with us. Our chairperson is first Professor Dr. Hariom Aggarwal, who is the professor and head at Government Medical College, Patiala, Punjab. He is the organizing chairman of North Zone of Orthopedic Association Conference 2024, organizing chairman for Punjab Orthopedic Association Conference 2023, and he is the president-elect of Punjab Orthopedic Association as well for 24-25. Being the executive committee member of IOA, president of Patiala Orthopedic Society, the external examiner for MS, DNB at many institutes, is an invited faculty on orthopedic PG course, is a National Medical Council assessor for medical colleges by National Board of Examinations, member of Ethics Committee, CDSCO of Government of India. His area of interest in hip and knee orthoplasty, pelvic and pediatric orthopedics as well. And he's a state trainer in clubfoot, life member of various organizations, and he has presented papers and published numerous publications. Welcome, Professor Hariom Aggarwal, today to this episode of Controversy and Consensus. Thank you for joining. Our eminent moderator, another eminent moderator is Professor Dr. SUSHRUT BABHULKAR from Nagpur, India, and Dr. SUSHRUT is a close dear friend. He is the chief of Center for Joint Reconstruction Surgery at SUSHRUT Institute of Medical Sciences, Nagpur, and adjunct professor of orthopedics and traumatology at DM Medical College, Nagpur. He is a founder member of International Orthopedic and Trauma Association, member of Online Discussion Forum Committee of OTA, and the president of Trauma Society of India and president of NELS, National Association of Interlocking Surgeons. And every year, as you know, SUSHRUT organizes a beautiful conference, which is TraumaCon in Mumbai, in August, second week of August, and most of you must have attended this, and we really enjoy attending this meeting. Welcome, SUSHRUT, to this episode of Controversy and Consensus, and thank you for joining here. Now, without any further ado, may I invite Professor Vivek Trikha to elaborate on his lecture, and then we have a discussion which will be generated by Professor Aggarwal and Professor BABHULKAR. Over to Vivek, please.
Okay, so thank you, Professor Mohanty, Dr. Deepak, Dr. Ashish, and with the permission of the moderators out here, Dr. BABHULKAR and Dr. Aggarwal, I'll be speaking on a topic which is apparently quite controversial, but for me, it's a straightforward thing, which is extreme nailing in tibial fractures. First of all, let me acknowledge the team. This is my ortho team. This is my unit where we all work together. And many of these cases have been contributed by all of us together out here, which we have been doing in our unit for the last so many years now. This roughly we started around 5 to 6 years back, and all of them have been there who have contributed. Dr. Samar, Dr. Nishank, Dr. Arvind, they are my consultant colleagues, and the rest are the residents who gratefully do these cases along with us, and we also learn from them. First of all, let me give you some background regarding it. Nailing, as we know, the tibial fractures started from plasters, functional bracing, and nailing to interlock nails. And now nailing has become the most preferred method of treatment for tibial fractures. The problems with the interior of the more proximal fractures was that the patellar tendon insertion causes the anterior angulation, while the pes inserinus causes it to go medially and leads to a valgus angulation. That's why many a times the proximal fractures, plating was usually preferred by all of us. Why? Because when we were doing the infrapatellar nailings and we are flexing the knee for more than 90 degrees, the fluoroscopy for the entry point in coronal plane was not possible because the lower part used to head and push the table up. And the quadriceps pull, the nail entry point used to become very anterior and go posterior, leading to flexion and procurvatum deformities. Hence, mostly we tried to use the plates for this. There was a time when we were using nails initially, then came the plates. Valgus deformity, this was the problems with the proximal nails, which we were having, the infrapatellar nails. The same thing, the deforming forces of pes, as well as the anterior procurvatum deformity, which used to happen because of the pull of the quadriceps. What happens with this is because once you are flexing the knee, the proximal fragment, when it was a small fragment, used to pull the proximal fragment more anteriorly. The gastrocnemius and the hamstrings, which were attached to the femoral places, used to flex the fracture. And we had an entry which was more anterior going proximally, posteriorly, leading to an eccentric sagittal reaming. Hence, we all went about doing these fractures with the nailing, with the plating. And there, at the same time, just in the conversion of the millennium, there was the advent of the locking plates, the periarticular locking plates, which came. And these ones became the standard for treatment of extraarticular fractures, which were very in the extremes, proximal and distal. However, they also had their problems of trying to maintain the alignment, which was so very dependent upon how you place the plates. Sometimes the distal screws were there, which used to be put in in a long fracture. They had to be put by mobilizing the anterior compartment. And you need it also sometimes to ensure that you are not damaging the superficial peroneal nerve when you had to use a specific length of plate, which was so very essential when you are using the locking plate principles. I'll show you, this is one of my own cases, and I have taken some slides, I'll say, which I presented once in TraumaCon roughly around 2006 or 7, when we were showing the extraarticular proximal tibial fractures being treated by plating. So this is one of the fractures which was high proximal fracture with a combination at the metaphysio-diaphyseal junction. And this is how we were putting and using a sliding MIPO technique and fixing it with whichever plate we had. Sometimes we didn't have those periarticular plates. So we had an LCP which was slightly curved in that sense, and we used to put them in this fashion. But you can see that in the sagittal view, there was some angulation, which was more anterior. In fact, if you look at the literature just 20 years back by Mohit Bhandari and an evidence-based orthopedic trauma working group, apparently at that time, the infrapatellar nailing used to cause higher prevalence of malreduction. And hence, they were not very much used as compared to the plates and the screws and the locking plates. However, one thing which was still at that time prevalent was lower infection rate after intramedullary nailing. And this was for the extra-articular proximal fractures. Just think about the distal tibial fractures also, where soft tissue is a major concern. And many of the fractures have an abrasion or an open wound, and how the infections and the soft tissue problems can happen with the plating. Remember, this working group results were with infrapatellar nailing and not with the suprapatellar or semi-extended nailings, which came around about that time when this study had come out. Over the last 20 years, the changes in approach were brought by Tornetta in '96, who started the semi-extended position with a big parapatellar arthrotomy. Slowly, they found out that with this, with the opening of such an open of the knee, it was not essential, and they started using an extra-articular entry point, but more proximal entry point, where the knee need not be flexed to 90 degrees. And Dean Cole started the suprapatellar entry point in around about 2005 to 2006, where why it came into India so late, roughly in 2016 and 17, was once the usage, but the problem in delay was because of the lack of instrumentations. People were, because you needed some specific higher grade instrumentation for this, longer jigs and longer reamers, which were not required for the Tornetta's method of a medial parapatellar arthrotomy. Hence, the suprapatellar is a very recent entry for these fractures where the nailing is concerned for the tibia. What is the benefit of these? Once you are putting the patient in a supine position with 10 to 15 degrees of flexion, your extensor mechanism is relaxed. So there's no anterior angulation. The sagittal plane entry can be easily taken care, and as well as the radiography. It has been very clearly shown that by the reduction in the intraoperative images with the suprapatellar nailing is very less as compared to an infrapatellar or as compared to a minimally invasive surgeries. And there was only one position of leg where you needed to keep it, which was in supine with 15 degrees of flexion. And you could easily correct the coronal plane deformities by just having your driver with the hand going this way or the medial or the lateral side. While with a bump on the posterior side, you could correct the sagittal plane deformities. Yes, this is again a paper at 2010, before which it was considered to be a technically demanding surgery. So you can see that suprapatellar nailing was considered, just has come recently over the 10-15 years. And that's why very less literature is evident right now. But this literature in 2010 started showing that it does not possess or poses a significant risk of articular damage to the patellofemoral joint, as was suspected by most of the people. In fact, if you look at this paper, which started around 2015 to 16, you can see that the rate of malalignment of distal 1/3 tibial fractures. In fact, suprapatellar nailing was the first used for distal tibial fractures, where they found that the malalignment was reduced very significantly from 26% with an infrapatellar technique to a 3.8% in suprapatellar part. Also, regarding the articular damage, this is a paper in 2013 itself, and I showed you a paper in 2010, which suggested that there was not any major intra-articular damage vis-a-vis as compared to other techniques. So what is the technique? It's basically that you are flexing the knee to 15 to 20 degrees. Before that, you need to look for the patellar mobility, whether you are able to do the patellar mobility. You are able to put in your jig and the sleeve below the patella at the trochlear groove, and you give an incision around 2 centimeters above the patella in the quadriceps tendon. And then with the finger dissections, you can just take out the suprapatellar pouch region, go intra-articular, and from there with the long jig, you can just sleeve, you can go up to the proximal part of tibia, where the extra-articular entry point can be very easily made. With the positioning of the patient and the leg, it is so easy to do that your guide wire does not go posterior, because the patella is acting as a barrier which does not allow your sleeve to go so at an angulation that it goes so posterior. And hence, with the advent of newer nails, with the slow Herzog bend or a small Herzog bends, these extra-articular but very proximal tibial fractures, and for that matter, distal tibial fractures, can now be managed with this technique very easily. So what are extremes of nailing? These are the fractures which we are going to deal with: intra-articular, combined intra-articular and shaft fractures, the metaphyseal area, both proximal and distal, and the segmental fractures, which all previously we were combining, or we were using 2 plates or a single plate, a very long plate, can now be managed by a nail alone, which is suprapatellar, usually by the technique. And in cases of combined intra-articular fractures, you can be using a plate along with this sort of a nailing. I'll be showing you some examples to drill into your mind how exactly this extent of suprapatellar nailing can be used in a variety of extreme nailings, which were not so feasible around 10 years back in India. This is the case of 28-year-old male possible who was having a lot of polytrauma injuries. You can see at a pelvis, femur, and a lot of open wounds as well. We fixed, and he had to be done a pelvic packing, the ICU he was having a neck femur with a sharp femur. And this was his proximal tibial intra-articular fracture. You see that the length of it is just 6 centimeters, somewhere going up to 5 centimeters. Very high proximal from the joint part. Having an intra-articular component with a patellar fracture as well, but it was okay, the retinaculum was intact. We could have done any of these options, but we chose, because of our technique and our usage, this is how we did that. We first fixed with the C-articular clamp, fixed and made sure that our articular fracture is taken care of. Multiple KYs were put more posteriorly in position in the axial section. Then you can easily reduce your distal fracture, because remember, all of this is being done in supine position with 15 degrees of flexion. And once you have been able to reduce these fractures, you can just put in the nail with the guide wire, which is so interior and does not allow the angulations to happen. You can see in the lateral view how well the reduction can be held with the K-wires going posteriorly and the guide wire of the suprapatellar going just at the place where you want it to be, as well as not too posterior. And subsequently, with the nowadays the advent of polyaxial screws, which here you can put at least 4 screws can be put in the proximal or in the distal fragments. All these fractures can be taken care, where in the end, you could finally replace the K-wires with the intra-articular, with the partially threaded screws holding the intra-articular component. The other fractures were also subsequently fixed. And this was the position which we had got. Remember that that patient had an open wound of the calcaneum, and hence we had to use a smaller nail because we had a thought of that it might have to have a chance of amputation. So we left it just below so that even if a BK has to be done, we will be able to maintain the nail at the same place where we want it to be. This was the post-operative, and see that all those open wounds which were there were easily bypassed. We could not have done an infrapatellar, we could not have done a plating at the lateral part, but with the suprapatellar entry point, all this fracture of the proximal tibia intra-articular could be managed like this. That's his 4 months follow-up, and you can see that his intra-articular thing as well as the fracture has united, as well as the other fractures are also there. And this is his later X-ray where you see the articular fracture is also well maintained. Another open grade fracture. Most of the fractures invariably of the proximal tibia have their abrasions and their wounds on the proximal part near the patella because of the superficial thing. And hence, many a times intrapatellar nailing may not be possible. And there comes the role of a suprapatellar nailing. Again, the same techniques with some amount of blocking K-wires which were used out here. And with the proximal fragments, you can see that with the 4 screws, with an additional screw if you want, you can easily get the angle, the alignment, the rotations part, and the varus valgus can be taken care just in this suprapatellar nailing part. You could see that wound. It later on, you can see with a lot of staples, it had a whack done, the debridements, the bone was visible. It later on had to be taken up for a flap. And this was possible because we could get in a suprapatellar entry point and get in this extreme of fracture, managed with a nail, which was able to be, and this is his final 6 months follow-up. There is a slight amount of varus, which we feel was because of the various manipulations and the things where the bone had to be taken out. But with the flap and now with the no wound, this patient is also okay. High proximal tibial fractures, so high fractures, around 5 to 6 centimeters in a 58-year-old male. Again, you can see that how well, without the usage of the blocking screws in most of the cases. If yes, if you want, you can use them both posteriorly and depending upon your angulation, either laterally or medially. But see that within 2 to 3 months, the same alignment with the 4 screws and such a good range of motion can be obtained in a high proximal fracture, where the fracture sometimes unites in a delayed way. Many cases, again, 4 centimeters, somewhere it going about 2 centimeters of the proximal extent. This sort of fracture also can very easily be managed with 1 screw, which is holding that fragment, and the rest 4 screws with the same technique, using and maintaining the alignment, which was not possible with your infrapatellar nails before. These were the proximal tibial extreme fractures. Sometimes you have segmental with articular fractures. And here also you can do the same thing as I showed you before. Lift up your depressions, hold with them with K-wires or screws. And once you have been able to do that, and if they are posterior in their axial sections, again, the nailing can be combined out here. You don't have to use the same incision. The incision for the nailing can be supra, which is not affecting your in reduction of the articular cartilage or the articular fragment. You can even put in a plate out here, and hence these segmental or articular fractures can also be taken care very well with these 2 incisions, which were not possible to do before with either a plate alone or with an infrapatellar nail. This was initially one of my cases where we started doing, because of these wounds, we had to put in a fixator. And as the wounds deteriorated, we had no other technique or a choice but to go in with a nail and a plate technique, where we were able to fix it along with the plate, held the K-wires, the articular fragment, and then put in our nail, and then subsequently removing those K-wires and holding and buttressing with a plate. See how in 2 months and in 6 months, the articular as well as all the fractures have united. This is a fracture which we, along with my colleagues, Dr. Samarth, we just did it recently, around, I think in October itself, such a comminuted type 6 sort of a tibial fracture. And this was our result. We reduced the fracture first, held the articular fragments, and then putting in a nail plate combinations in a combined articular with extreme fracture of proximal. And this is his 7 days post-op. You can see the clinical picture where the incision for the suprapatellar and a small incision for the plate has been put. And you can also see the range of motion which can come up so well early enough so that the mobilization of the patient can be done fast. Segmental fractures, high proximal and distal. This is my own case, which I had treated long time back with 2 plates, one going up, one going down on the either side. Because at that time, we didn't know how to put in those nails with the infrapatellar part. But similar case, which has come to us now, this was 10 years later, a similar case with a high proximal and a low distal fracture, segmental fracture, treated with a suprapatellar nail, and you can see how well the alignment can be maintained with minimal morbidities and good results for the patient. These are the segmental fractures which can so very well be managed, the extremes of fracture with follow-ups, as well as the good union and good range of motion, which avoids the morbidities which can be there. This is the extreme fracture, I would say, very high proximal and very low distal fracture in the same patient. Now, again, either we use 2 plates on either side, or if we are possible, we can be using, there was a fibular fracture as well. And this is what we did with a nail as well as a suprapatellar nail. We went in, way out. We were able to get 3 screws down and 3 screws up. We fixed the plate for the fibula as well. And we are looking at his follow-up. But yes, it is possible to manage it with a single implant, with less morbidity, with no issues regarding the wounds, and that's you can do. Distal tibial, yes. Many people are wary of managing distal tibial fractures with plating because of the wound issues. But the nailing also, infrapatellar, does not give you, because of the flexion, you are not able to correct the angulations. And with small fragments and with the single 2 screws which were available before, nailing was not an option. But now with the advent of polyaxial multi-planar screws which you have, along with the entry as well as the supine position where the sagittal as well as the coronal part of the alignment can be checked very well, you can do a suprapatellar nail for such fractures, such distal fractures with roughly 3 to 4 centimeters of distal tibial articular. You can see that the fracture is extending just 3.5 centimeters above the joint. However, you can do this fracture by putting in reduction, because all these imagings are so easy to do in a supine position. You have to move your image. You don't have to move the patient. With an upper tibial pin, you can just, lower calcaneal pin, you can just drive in whichever way you want the coronal plane to be aligned. And with a bump on the posterior side, if you keep a bump proximally just at the fracture site, you can even correct the sagittal angulation of that. And subsequently, you can put in the screws. You can see that it has got post-operatively, and the range of motion is quite good. I'll show you some more case to convince you regarding the extreme nailings out here. With the 60-year-old male distal tibial fracture, you can see again 3 screws down in a supine position, 6 weeks follow-up, 15 weeks follow-up, and you can see that these fractures are uniting. No soft tissue issues which you have to deal with when you are opening with a plate, and no Elizarovs or the ring fixators to be put, because the open wounds or the other issues and the mobilization of the patient can be done very fast. This case I've already shown you. This is the case which my colleague had done. This was one of the distal fractures, and nowadays we use this technique quite often for elderly patients who have distal fractures. In fact, one of these cases has been done today, tonight itself, in the evening, by one of my colleagues out here. There's such a distal fracture, similar fracture, but not so comminuted, where we put in the nailing. You can see by the hand manipulation only, the nailing and the entry point, as well as the distal entry in the both AP and lateral, have been properly put in with the guide wire, with an lower calcaneal pin. Once we were able to put in the nail, we tried to do an angulation, as you see on the 3rd and the 4th images of the proximal row, where we found that there was some opening still because of the metaphyseal area. And then we slid in a small plate with 2 incisions, one lower down and one up. And this was the way we can see with the staples how small incisions were put for such a big fracture. And an adequate amount of stability was obtained for such a distal fracture with a big metaphyseal-diphyseal combination without damaging the soft tissues for such patients. In the end, I will say that yes, this technique of indications of nailing has increased over the years. There's a cycle, I would say 20 years back, 15 years back, we were using only the plating and the periarticular plates for such fractures. We didn't have any other options for open fractures, for abrasions or bad skin conditions. And we also had to deal with the angulation part. But with the advent of the semi-extended positions and the advent of newer armamentarium of polyaxial screws, where you have multiplanar screws to give good hold, you are able to use these high extreme proximal and distal fractures also with nailing. And if you feel that the stability achieved is not good in an elderly patient or in a highly comminuted patient, you can add on an augmentation plate for it. However, get a CT scan if you are going in for a very high extreme fractures like 3 to 4 centimeter of the joint or the fragment which is left. You should know your nail proper, because you need at least 2 to 3 screws in different planes to be able to be put in that small fragment. So your cutoff will be 3 screws in the distal or the proximal fragment, which are in 2 planes at least, and that you can find out only in a CT scan, easily managed with the technique which allows us more ability and more power to control the angulations, as well as see them under imaging. If you are having an osteoporotic fracture, you can use and combine these techniques with the even screw augmentations or plate augmentations for intra-articular fractures. As I said, the malreductions can easily be controlled here, and it really facilitates the ease of fixation. I can tell you that many of these cases are done in my unit in emergency in the night by my residents, who are now very proficient, and I'm proud of them that they're able to do these fractures, such high fractures, because of the ease also and their learning also. And I feel that this is going to be a useful tool in the armamentarium of trauma surgeon, because sometimes you have seen that the soft tissue part is very less damaged. You're able to get the mechanical stability. You're able to correct the malreductions and the alignments issues, which was so very common with also the plate as well as the infrapatellar nailing. And also you can combine these things with the plates or the screws in some fractures which are associated with this, or in elderly bones where the stability sometimes is the main issue. Thank you very much for your hearing. And now we can have a good discussion on this controversial topic.
Thank you. Thank you, Vivek. That's an excellent exposition of the, suprapatellar nailing for the extremes of fractures. Before I, hand over to the moderators, I have just a small question. I don't do much of trauma, but for upper third tibial fractures, I can understand that suprapatellar nailing could be a better choice to neutralize the forces. For lower third tibial fractures, unless there is a soft tissue injury around the nail entry side, still you will prefer a suprapatellar, or a standard entry point for the nail would be ideal or preferable, rather, I would tell.
No. Look, I would say that the entry point is not very crucial for putting in these nails. It is the position which you apply and align with the entry points which makes the difference. If I can somehow do the infrapatellar nailing in these cases with an alignment in supine position, I'm okay with that. But it is not possible to do it. When we do a femur nailing, we are aligning our entry point with the trochanter, which is in straight line with the medulla. But in tibia, we have always taken a bend of it in infrapatellar nailing, and we try to go first posteriorly and then go down. But now this is going to be more in alignment with the medullary cavity length and alignment of the medullary cavity, and that's what the suprapatellar gives us. So it is just a positioning of your guide wire in such a position that you don't have to manipulate your fragments in those conditions, and then you can put in the entry and the things which are there. So it's the position of the bone and the flexion of the knee, which is the crucial thing, which many a times. The second thing is how much control you have regarding the intraoperative images. And I can tell you that imaging, maybe I was not very an expert, or we were all not very experts in infrapatellar, because the people who are masters in infrapatellar could just put in the entry and do it whichever way they wanted. But still, even if you are doing it in a figure of 4 position, which was the normal way of doing it, or you are doing it on the side of your table and putting it behind the next to the table by putting in an OT sterile towel and going down and then pulling the distal fragment, think about the imaging and what control you have regarding the alignment. Here, the position is the anatomical functional position as we see in a supine position. So you have 3 basic, if I can say, deformities or things to control. One is the mediolateral part, one is the sagittal plane, one is the coronal plane, and the rotational and length. So length you are easily seeing under image. The coronal plane angulations can be just corrected by your calcaneal pin traction, which is just going like a hand screw, like a scooter drive, a two-wheeler drive, or a handle, which you go this way or that way. And a small bump below your angulation can easily correct your sagittal plane. So you just have to look at this bump, which is going to give you, but rest everything is there. And the visualization of that is so very easy to do, which was not possible with infrared. So distal fractures, I agree, it's not that angulations or the muscle pulls which are taking part, but our control in the distal fractures with management of infrapatellar nailing in extremes of those nails or the fractures which we have shown from our team to you right now, the visualization of them while managing them becomes so very easy with a nail when you are doing it in supine or semi-extended position. That's what I would like to say.
Thank you. Thank you. Over to SUSHRUT and Professor Hariom Agrawal.
So, if I have to say, I cannot agree more with Vivek. I think we all got completely sold with suprapatellar approach. And Shubhranshu, for lower third tibia, there is no better position than a supine position to bang in the nail and to be able to control manually your tiny lower third or lower fourth, or let's say lower sixth tibia fragment, and putting a nail from the top. If I want to argue with you, Vivek, today and debate on suprapatellar versus not infrapatellar, but another approach, which I learned only a year ago along with you in TraumaCon of Rodrigo Pesantes.
The lateral.
And it's a fantastic approach. After last TraumaCon, I did 20 cases, upper third, upper fourth, and lower third, lower fourth, using his approach. A parapatellar, medial, extraarticular approach, and it's absolutely phenomenal. You go parapatellar, you go over the retropatellar pad of fat, you excise the retropatellar pad of fat, you are still extra synovial, and you enter right at the spot where you desire to. Your leg is still in supine position or semi-extended position, and you can control your upper third fragment, you can control your lower third fragment exactly the same. I've written it up and I'm going to put it as a clinical note in injury, which we are editing together.
No, I fully agree with you. I would say that what is the crux is the positioning of that leg.
Yes, true.
If you are, as I said in my first sentence, that if somehow I can do an infrapatellar nailing in a supine position with a 15-degree or the thing, I am very well will get sold to it. The only
problem which I also faced with suprapatellar, a lot of patients who came back to me from my region, from my part of the world, where patients who had compound injuries, people did suprapatellar, and the whole knee got fired, getting infected.
Right.
So the fracture site got infected, and it got migrated to the joint.
Yeah, so that I know is very big apprehension among the minds of everyone. But if you look at the world literature, there are 2 big papers onto that. One is by Mitchell and Corey Collins in 2017. And then there is another paper in 2019. and where they compared a suprapatellar or the so-called intra-articular entry point as well vis-a-vis the infrapatellar one, which is an extra-articular entry point. And what they found was in open fractures, and for the benefit of the people who are listening, I would say that in that they had around 140 cases, 139 cases to be exact, in open grade 2 and 3 fractures, where they did a suprapatellar nail. And they found that, yes, the standard open fractures had their non-unions and stuff, which were there was around 18%, as the same as other things.
True.
However, there was only one case or two cases of knee sepsis or septic arthritis or so, which we want and are afraid of because of an intra-articular entry. And the other one, which they compared with infrapatellar one, also had similar results. So open grades also we can use. And if we can avoid an intra-articular entry point, there will be nothing. Sone pe suhaga, as we say, will be the ones which will.
So in my life, I completely agree. In my life, I got 2 patients operated somewhere else who got pyoarthrosis. And unfortunately, I mean, they would have got infected any which ways.
Right.
But here, surgeon chose to do suprapatellar and the guy got fired. And second apprehension that I have for our colleagues is they need a separate jig, a longer reamer, separate special instrumentation for this. So maybe at peripheral centers, they may not have access to it.
I would just,
Rodrigo Pesante's approach, maybe means I have done it in around 40 plus cases now. I could negotiate using the same conventional instrumentation. But terrific talk, Vivek, and I completely agree with you on suprapatellar and its advantages.
Yes, agreed. I would just add on to thing is that suprapatellar is just opening our eyes and ideas and making us amenable to doing a nailing in tibia in a supine position. And that has what it has brought us. So now the focus after some time is not going to be infrapatellar nailing. It is going to be nailing in supine position. Let's not talk of the incision. Let's talk about the position in which we are placing the patient. And with that, we can have great approaches, as you are saying of Rodrigo, which is medial parapatellar but extra synovial. Then, as was there by some other people who are using a lateral extra synovial and extra capsular approach, which do not, as you very rightly said, do not require the lengthened reamers and the lengthened jigs, which are required for suprapatellar. But now the focus and the outlook and the mindset has shifted from putting the patient in a flexion of 90 degrees or excessive to just 15 degrees. And now we are going to have newer approaches which are going to be brought out, which is going to get refined over the years, as Dr. SUSHRUT is just saying, with an extra-articular or extra-synovial, not going suprapatellar, but side. Because sometimes in osteoarthritis or in other cases, the patellar ballotment and those cases, you might have some issues pushing it down.
Absolutely.
So their extra-synovial or approaches, our focus is to shift the mindset towards an supine, semi-extended or 15-degree position, so that we can get good alignment with less radiation to the patient as well as to the surgeon. If possible, with the same instrumentation, that will be the best thing to do.
Can I ask you a question, Vivek? A technical question. You did that intra-articular proximal tibia fracture so beautifully, putting a plate there. So what's your strategy? How do you place the screws? Of course, they have to be posteriorly, more posteriorly. But if there is an anterior fragment which you want to control, more in the anterior quadrant, then what's your strategy?
For that, we need to, as I said, the CT scan will be a very essential thing to understand for. And we normally, whenever we are having such fractures, we normally give a lot of time to understand the axial sections as well as where, and the coronal sections, to understand where exactly the depression is or where exactly the displacements are. These two things we need to look. Majority of times, the displacements or the depressions which we have are usually not very anterior. They are either in the middle or in the posterior part. So those can easily be done by just lifting it up, and you can put in those wires as I showed you. And whenever we are using the plates for them, our proximal and the most anterior row usually goes empty. And we use a two-row proximal tibial periarticular plates, so that we have more 3 or 4 screws on the posterior part, which gives us a good fixation. And then once your nail goes posteriorly, then your screws can come anterior as well as posteriorly, where there is a good chunk. However, if the displacement is more an anterior fragment, then what we do is we put in 1 or 2, we look at where exactly and how big that chunk is. Many a times we had a tibial tuberosity or an anterior fragment which is going up. So we normally tend to have and see where exactly the more area is there on the medial side. Then we try to put in 2 KYS and hold it in that position in a supine, which is so easy to do. Hold it with KYS and try to see if our nail screws, which are now in multi-directional, are going to help us in the anterior screws. Yes. If not, then we are not very hesitant to put in a small plate, because now we can open up wherever we want, because our incision is not there. It is suprapatellar. So we can give a small incision and buttress that fragment with a small mini plate wherever.
Okay.
I think these are the easier to do in the expert hand.
Sir, that's why you say my second slide showed my residents out there. And I am showing, and in the end also I said that many of these cases were done by not by me alone, but by my residents out there. Because technical learning curve out here is less, because you don't have to do much for the reduction part, which we were so much fixated with and difficult to do when we are doing it in the figure of 4 or in a slide on the side of the table position. So reduction part is easier. You can hold it and you can change it with good visualization. If a junior person is there, he uses more image. That's the only issue. But here he can get good visualization with images, which was not possible before.
Sir, wonderful watching you. Wonderful. It was awesome to see the complex type of high tibial fracture, which you shown simplified with the nailing. I say it was really complex fracture, which you handled very simplified.
My team, sir. I would say I'll give my things, because these are not all my cases, as I said.
This is the most technically demanding surgery, but because of the latest instrumentation, now the surgery has become quite easier to do and feasible.
Yeah, I would also say that the usage of blocking screws or polar screws has also dramatically decreased now, because the angulations or the displacements which were there are not prevalent now in these positions. As soon as you put the patient in supine under anesthesia in this position and just give traction, you find that most of your alignments are okay. You just need 1 or 2 planar deformities which need to be corrected.
And definitely, sir, nailing has the advantage over the plating in the lower limb, in the early weight bearing and the early rehabilitation.
Certainly,
all these things, this type of procedure, they are for early rehabilitation of the patient.
And the mobilization can be done very fast and very early, which we saw also.
Patient can return back to their work quite early.
Many of these fractures in the distal fragments take longer time to unite. And if you leave some gap with the plates, which we normally used to do, there is no way of dynamizing those plates ever. You need to do and add a bone graft out there, or a plate. Here you can do it with just dynamization also, and with the nail, we can use the benefit of the nail, which can be long drawn. And even a delayed union can be taken care by just small amount of invasion and interventions.
I just want to ask, for all distal fractures, you are doing managing them with the suprapatellar nailing, or in some cases you are also going for the infrapatellar nailing?
So in our hospital, just before COVID, we started doing this. I remember we gave a thesis to one of our residents out that time, and I would say that before COVID only, everybody was now had totally shifted. And now I can say that all my residents, I'll have to train them to do an infrapatellar rather than to do a suprapatellar one. So the only indication sometimes for us for doing an infrapatellar is the floating knee. Which floating knee is where we use the same.
I just want to ask one question, that there is a fear in the mind of the average surgeon, that is there any fear of damage to the articular cartilage of the patella or the distal femur with the jigs when we are inserting them and taking out?
Yeah, so there are 2 things which we need to be very cautious. I fully agree with the concerns which the people have for the articular damage, because if you do not do it proper way and you do not are not mindful of that, you might damage the articular trochlear fragment and the patellofemoral. However, all these instrumentations comes with a silicone sleeve, first of all, which needs to be used for such cases. The second thing is you should know and look where your patella is able to be ballotable and it is going to be medial or lateral mobility is possible or not. The third thing is you should be ensuring that your damage and that sleeve remains all the time inside that thing and it does not come out. Because if you are able to do, then with the sleeve on, you are just pushing in all your instrumentation through that same sleeve. There have been papers in the world, one from South Africa and one from Roy Sanders, if I remember, in the America as well, where they have looked at, and even my thesis and our thesis, which we had given, was looking at MRIs, arthroscopy 6 months later, along with MRI techniques and MRI after 6 months, and to look at the articular damage if there was any. And we were able to find that yes, if we could look at the initial thing, because of our learning curve, there was some articular things, but they were not very significant because our people and the diagnosis was given by the radiologists. And arthroscopically also, we had in few cases only, we couldn't get all the 45 cases for arthroscopy because nobody agreed in those sense. But around 15 cases, which we were able to do arthroscopically diagnostic after 6 months, there was not much appreciable patellar damage or the trochlear articular damage, except in few cases, which I would say that was because of our learning curve, because they were the initial cases where we had this.
Whether age was any concern in any of the case, sometimes the patient with the severe osteoarthritis, he gets the fractured tibia.
Only things which we need to look for is that how much the flexion we are able to get in the knee, whether it is there or not. Even if थोड़ा सा तो flexion होना चाहिए, full extension भी हो तो थोड़ा सा मुश्किल हो सकता है, and because उसके stiffness के कारण. But otherwise, even in that, you can do that. That's not an issue. Yes, patella needs to be ballotable, or if required, you can have to lift it up, see where exactly your patella is going medially more or laterally more. And then there are options of going, as Professor BABHULKAR was also saying, that you can go medial or lateral rather than supra to the patella and get your entries if required for that, which will not require your jigs and the sleeves to go below the patella, rather on the sides of it.
Thank you, sir. It was wonderful listening to you.
Thank you, sir.
Quite informative.
Thank you, sir.
Any other question from the doctor?
Yes, sir. I would like to ask a question to Dr. Trikha. Sir, there are two questions actually. One is, there are numerous companies which have come up with these nails. So can you tell us something? I mean, it's, of course, you'll have to name the companies. There are different companies which come with a different sleeve in the patellofemoral joint. As you mentioned, they all have a silicone sleeve, but the diameters are all different. So who has the narrowest one, and which one do you find is the most easiest one to insert atraumatically? Or
I would say that we haven't been using and trying multiple companies also. We are using only one MNC and one Indian company for whose we are using this, who were the pioneers in this. And I would say that both of them are actually MNCs who brought that here. I wouldn't be naming it. We will be discussing them anytime whenever we are discussing that. But yes, I would say that you need to look for the sleeves because it will depend upon your nail as well, which you are putting in. It has to be at least 10 mm. But what I found and what we found in our studies when we look back at 6 months of arthroscopies, and we had again a debriefing with our residents, what exactly and how was the technique, many of the people were missing out. And what happens is many of the companies do not give you and provide you with this sleeve, silicone sleeve, all the times. Other thing which can happen is many of them are used multiple times by people. And then they can have an issue of getting cut or torn in between when you are using and removing those jigs and the reamers. So you need to ensure that your sleeve and silicones ones are the disposable ones or very good one quality, but they have to accommodate your nail as well as your reamers for that.
Okay. The other one is a technical one, because what we have found is that towards the end of the surgery, when we remove the jigs and when you dismantle it, when we put our finger into the patellofemoral joint, we sometimes find an impression that has been created onto the trochlea.
That again, I would say, is depending upon what position you are giving to your thing, in the sense that in your knee position. If you are giving a very big flexion, or you are giving it at what exactly, or you're putting it at extension. If you are able to keep it at more extension after putting in your guide wire, I would say that your trochlear impression, which happens, pressure impression will be least. But if you keep it at 15 to 20 degrees at that time, and then you are angulating it, then all the nails and everything, there are only 2 times when you have the maximum articular damage or pressure to the nail or to the trochlear area. One is once you are putting in that sleeve inside, and the second one once you have is when you're putting in the nail inside. Right. Otherwise, most of the other times, the other things are not the ones which are causing those articular impression. So be cautious while you are putting in the sleeve. There are people, as we all know, Dr. Shiv Shankar says that you need to push in the saline also, so that you make the patella more ballotable. That's also a very good technique of doing and ensuring that your knee joint and the things in the patella becomes much more upwards, so that you don't have any pressure which is going there. Try to make sure, one thing which you need, that the suprapatellar area, the pouches, you are able to, with your finger, you do a proper dissection of area, so that all those plica and the suprapatellar pouch which has been formed, you are able to clear that properly. Then only your patella becomes much more mobile, and you are able to reduce the damage to the articular area.
Secondly, how easy or difficult it is to see the exact length of the nail. With the infrapatellar, which you have been used to, you see the end of the nail, there is a jig, there is a thing. But here, the end of the nail is quite deep inside.
They have their instrumentation where you have those entry or the guide wire placement or a K wire placement also, which can give you those things. And we normally tend to put in one size less, because you have now an end caps which are of 5 millimeters.
Yeah.
So the end caps are going to give you the idea. So we normally tend to go on to the lesser size of the nail rather than on the proximal side if required, for the distal fragments at least. And
Right.
even for the proximal ones, because we can always go once up to one. We have, if we see, we have 5 millimeter nail increments because of the end caps every time.
Dr. Vivek?
Yes, sir.
Can you tell us any condition where you will not like to do the suprapatellar nailing?
He told now that segmental fracture.
No, segmental also you can.
Floating knee, sorry.
Floating knees are one. There are 2 or 3 conditions where I would not be very enthusiastic of doing that. One is in a severe osteoarthritis case, where I feel that I'm going to do much more damage to the thing. And if it is a diaphyseal one, I'll go back to my routine position, which we were doing before. I'll not be sacrosanct. I'm not a person who has to do this also. The second one sometimes is, there's a lot of discussion in my unit regarding the floating knee part, where some of my other colleagues want to do it through suprapatellar alone and the nail of the retrograde through the infrapatellar part. But there I feel, that's my own personal instinct is there, that I would go in for, if the fracture of the tibia is in a diaphyseal region, which is quite amenable with an infrapatellar nail, I would be more inclined to do that. But yes, now once we do in for a suprapatellar and we are so happy and at ease with that, when we do such cases in a infrapatellar, it takes us more time to do it.
Yeah,
and then it reinforces the thing that might as well do a suprapatellar and come out very fast with the imaging things.
Good.
And lastly, this is a question regarding implant removal. So implant removal can be through an infrapatellar approach, right?
Yeah, it can be done through both the approaches, both infra and supra. And there is no problem if you have put in the implant properly and your end cap properly and not cold welded it or tried to put it eccentrically. That will not be an issue, because then you have the instrumentation where you can easily bring it out as well.
Okay, so we have just 1 minute to go. I think we'll wind up here. We really thank Professor Vivek Trikha for giving an excellent lecture and giving us, all the discussions pertaining to the lecture, that when not to use, how to use, what are the technical difficulties and what are the do's and do nots while handling this kind of fractures. We really thank you for your time. We thank Professor Hariom Agrawal also on a working day in the evening. Thank you, sir, for joining here and devoting your time for this.
It was an honor. It was an honor for me.
Thank you, sir.
A part of such a very excellent academic meet.
Thank you, sir. And thank you, Professor SUSHRUT BABHULKAR, for joining again on a working day in the evening and generating discussions on this.
Thanks, Shubhranshu. Appreciate that.
At least personally, I gained a lot today, and I can guide my residents also in the direction of this type of nailing. Thank you very much. Now,
And it was a great talk from Vivek, and good to see you, Ashish.
Thank you. Good to see you, sir. Yes, sir.
Now I hand over to ASHISH to give concluding remarks, then we'll wind up.
Thank you very much, sir. And I would like to thank Dr. Vivek Trikha, Dr. SUSHRUT BABHULKAR, and Dr. Hariom Aggarwal for being with us today. And though this session is titled Controversies and Consensus in Orthopedics, I think today it was very easy to reach a consensus that supine nailing of the tibial fractures in a supine position, especially in extreme situation, is probably the way to go ahead, and that is where we would see most of the thrust of the current developments going on, whether it's through a suprapatellar approach or whether it is through the modified, the newer parapatellar, extra-articular, extra-synovial approaches. So
And
we'll
if
keep on watching this space.
And if required, we can share our cases, difficult cases with Dr. Vivek.
Absolutely, sir. Absolutely. So we hope you have enjoyed this, and we would also welcome you for our next session, which will be in 2 weeks from now, and we'll keep you posted regarding the same. I thank you all for a very patient listening. Thank you very much.
Thank you.
And we
Thank
thank
you.
OrthoTV also, OrthoTV with Dr. Ashok, Shyam, Dr. Neeraj, Bijlani, and Maharishi also today for joining here and conducting the session. Thank you. Have a good, nice evening. Nice evening.
Bye-bye. Bye-bye. Bye.
Bye.
Bye, sir.
You can stop, live transmission.